Right.
Good afternoon and welcome to the Roche Idea Lab session on preeclampsia. My name is Brent Fuller, Product Manager for High Medical Value Reagents, and I'm joined today with Dr. Sarosh Rana, Section Chief of Maternal Fetal Medicine at the University of Chicago and subject matter expert on preeclampsia. So thank you for being here with us today, Dr. Rana.
Thank you.
So I'm grateful for the opportunity to shed some light on preeclampsia and the Black maternal health crisis and how diagnostics can improve patient outcomes. So Dr. Rana, to provide a foundation for the audience, what is preeclampsia and how common is it in the United States?
Yeah, so preeclampsia is a high blood pressure problem in pregnancy. It's kind of unique that it can only happen in people who are pregnant. So all the men out here, you will never suffer from preeclampsia. It's actually one of the commonest problems in pregnancy and one of the common hypertensive disorders. So here it says 7.6%, but they're variable. So 1 in 10 women can actually have it. And it's a major problem because one, and we'll talk about racial disparity, but preeclampsia can, one, occur suddenly. There are no specific signs and symptoms. And it's responsible for about 70,000 maternal deaths. So one of the common reasons of women dying in pregnancy and postpartum worldwide, and about 500,000 fetal and neonatal deaths. So it's one of the common problems, but also one of the common killers of mothers and babies. So very, very kind of dangerous problem.
So when we look at the image on the screen, it jumps out at you. The figures are drastic. So why are Black women at a higher risk of experiencing pregnancy-related complications?
Yeah, so as you can see there, this is, I think, the maternal mortality per 100,000. So about 3 to 4 times. So Black women are at much, much higher risk to have pregnancy complications and and especially hypertensive disorder. And if you ask why, obviously there's not a simple answer, because then if it was a simple answer, people would solve it. But I think there are multiple different things that are happening that will lead to an adverse outcome. So there is data that people who are African American, they are at higher risk to have comorbidities. So they will come into their pregnancies with high blood pressures, come into their pregnancy with uncontrolled diabetes. So then that makes them at higher risk to have adverse outcomes. Then they have poor access to care. Okay, so not only they have poor access to care, but they also have poor access to quality care. So there's actually data that Black women seek prenatal care in clinics and hospitals which are not super equipped and high risk. Then there is all these other things: gun violence, social situations, lack of poverty, the area where you're living in. And then there is all these things on the healthcare provider side, such as there is implicit bias, there's institutional bias. So all of those things ultimately, and then there's data that especially Black women, they're not really listened to. So if you go to your doctor's appointment, there's a high chance that if you're African American Black, the doctor will ignore your symptoms or will not actually listen to. So when you put all of those things together, then that leads to an adverse outcome.
Wow, thank you. So it's standard practice that diagnosis is the first step in a patient's journey. So do you feel that the current methods of diagnosis are accurate?
So if you're talking about preeclampsia,
Yes.
right? Yes. So the way we diagnose preeclampsia is very clinical, okay? So you need to have hypertension, high blood pressure. There's a criteria: blood pressure more than 140/90, and protein in your urine, all right? And then we check all these other labs. We check renal function, liver function. The reality is that the positive predictive value, that means if the test is positive, what are the chances the person is going to develop severe disease, is very poor. It's about 20%.
Wow.
Yeah. So the problem with, and some of these other lab tests is, one, they are really late in the course of the disease. So I would say, yes, the diagnostic criteria for preeclampsia is actually, current diagnostic criteria is very poor.
Okay.
Not accurate at all.
So can you talk about some of the risk factors patients should look for?
Yeah, so sure. So there are risk factors that predispose you to develop preeclampsia. So those would be if you are advanced maternal age, so moms over 35, if you have a BMI over 30, if you have twin pregnancy, if you have kidney disease, diabetes, lupus, all those predispose person to have preeclampsia. But I treat a lot of patients with hypertension. One of the things that everybody whoever is listening here, is that you as a patient should be aware of symptoms of preeclampsia. So things such as if you develop terrible headache, if you have spots in front of your eyes, if you have terrible pain in your belly, if you have vaginal bleeding, those could suggest that you are developing preeclampsia. So everybody should get written instructions from their doctors and should be really aware of symptoms of preeclampsia.
Okay.
You want to go back to that one?
Can you go back one
Can
slide?
we go back? Yeah. So we want to talk about the PRAECIS?
Sure.
Yeah.
We could talk about PRAECIS. So can you tell us a little bit about the PRAECIS study?
Yeah, so this graph here, what you guys can see, so what happens is, this was a large study that was recently done in US. It was done across 18 institutions. There are about 1,000 patients. And essentially what we are trying to figure out, if you take patients who have some sign and symptoms of preeclampsia, so whether you have hypertension and you have some lab abnormality, how do you know that this person is going to develop severe preeclampsia?
Yes.
Okay. Now that's an important thing to find because the management of preeclampsia really depends upon the severity of the disease and the gestational age.
Okay.
All right. So you don't want to miss people who are going to develop severe disease because they literally can die. But also you don't want to overdiagnose people because then you'll have prematurity.
Very true.
So you just have to have this balance of accurate diagnosis so that you can stratify people and say you are at high risk. I'm going to follow you closely because you're going to have an adverse outcome. But you're at low risk. I'm going to follow you standard of care but not going to deliver you and perhaps prevent iatrogenic prematurity. So this study was called PRAECIS. It was kind of based on the concept that we wanted to stratify patients based on the biomarker that we're going to talk about, S1 PLGF ratio, into high risk and low risk to develop preeclampsia with severe features. Okay. So if you look at the graph on the left, it's called an ROC curve. So essentially the lines are how good the predictor is and the area under the curve. So the left and high means a good test. So if you see there's one line that is kind of up there and rest of them are kind of all together. So that the one line that's up there and the most accurate is the S1 PLGF ratio. And that had an AUC, area under the curve, of 0.92. And everything else that we are using clinically, so blood pressures, lab work, creatinine, protein, platelet count, everything was less accurate for prediction of preeclampsia. So this was one of the large studies that was recently done and then led obviously to the FDA approval of these biomarkers. So we can go to the next slide and we can say what ACOG says. But currently, the FDA approved the use of S1 PLGF ratio with a cutoff number of 40 as a risk predictor for prediction of preeclampsia with severe features in singleton pregnancies, so persons with one fetus, not twins or triplets, in the gestational age of 23 and 35 weeks for prediction of severe disease within 2 weeks. Okay. And this is what the ACOG statement just came out in actually a couple
June,
of,
June
2 months ago,
2024.
is that, so obviously the idea here is not, we're not going to use the S1 PLGF ratio in isolation, right? Because when you're evaluating patients with preeclampsia, you look at everything, right? You look at the mom, you look at her symptoms, you look at her blood pressures, you look at the labs, you look at the baby, you want to make sure baby's growth is fine, baby's testing is fine. But what ACOG is saying is that use S1 PLGF as a complementary. So in collaboration with all other tests to find these people who are at high risk or people who are at low risk to develop preeclampsia with severe features.
So are there any guidelines other than the ACOG guidelines that recommend biomarkers to test for preeclampsia?
No. So since the FDA approval, and we just finished the study, I think you have that on the next slide, there are no real guidelines in the United States, but actually these biomarkers have been used for over a decade in countries in Europe, in India, in Asia. So there are actually the International Society for Study of Hypertension in Pregnancy. I'm part of that guideline. We actually put S1 PLGF in the definition of preeclampsia, yeah. But in the United States, the only guidance we have is this ACOG bulletin, which says that you can use the test. At least they didn't say don't use it. They're saying use it, but use it as a complementary test.
So this is a big
Very good
advancement.
thing, yes. It's a big plus.
So Dr. Rana, can you talk a little bit about how you incorporated biomarkers into your practice at the University of Chicago?
Yeah, so what happened was the FDA approved this in May of 2023. So what we did, one of the first things we did was we obviously generated a lot of, I was part of the PRAECIS. So I had a lot of knowledge. So one of the first things we did in the implementation, we actually did lots of grand rounds. I did small meetings. So I disseminated knowledge among the providers because I'm not the only doctor at University of Chicago, right? We have a large group of people. We train residents and fellows. So we disseminated knowledge. We did like lunch and learn with the nurses. We told people what these biomarkers are and how they can help our patients. We did a lot of patient education. We routinely do that for preeclampsia anyways. And then I developed this kind of guideline based on kind of our interpretation, but also how PRAECIS interpreted how we will use the information, right? So if you look up there, or look up there, so these are patients between the 23-week and 35-week of gestation. They're singleton pregnancies, and essentially they're all admitted patients. Okay, so currently FDA has not approved the test for outpatient use. You can only use it in an inpatient setting, and you are using it for patients who don't yet have severe preeclampsia, because that's what you're trying to figure out. So anybody with any other kind of hypertension, chronic hypertension, gestational hypertension, when you use, so you get the test, and the test will come back with a number, right? It'll say whatever number. So if it's less than 40, you tell the patient that you are at low risk. And how low? Well, the risk to develop severe preeclampsia within 2 weeks is less than 5%. Very low risk. And then they looked at all adverse outcomes. So very low risk to have adverse outcomes. So in that case, what do you do? Well, look at there. We say discuss the risk with the patient. Okay, so we go and we tell the patient, you know what, we got this test done. I know you have hypertension, but your risk to have severe preeclampsia is low. Then we just do expectant management per ACOG, right? So if ACOG says XYZ, do with chronic hypertension, that's what we do. We explicitly told all our physicians that admitting patient is already admitted, discharging the patient is entirely based on clinical scenario. You cannot discharge a patient just based on the test. And the second thing is delivery decisions should not be based on this test. So then if the test comes back positive and high risk, we say, well, we go tell the patient. We also created things like we created epic notes so people can quickly drop a note. And then we kind of internally developed this protocol to monitor these people more carefully. So these patients are continued admission. They're getting more frequent labs. We do more frequent fetal testing. We do more frequent growth ultrasounds, because high ratio is associated with severe preeclampsia, but also associated with growth restriction and adverse baby outcomes. So then you give them betamethasone, you prepare the mom. So I think it's really helpful to, and then I created this. This is published in ACOG. It just came out literally yesterday. And we kind of implemented this protocol. So every person who comes in and gets admitted, people get the lab, get the ratio, and then we manage them accordingly in terms of whether you're low risk or high risk.
Yeah, so that's great, and congratulations on the publication. So would you say that education is key?
Yeah, I think physician education is key. I think one of the big things that we do at the University of Chicago, we do have a large hypertension program. We do a lot of patient education. In fact, all our patients have to watch a video about preeclampsia every time they come in and get admitted to the hospital. So I would say yes. I think now that this is a little bit of a public knowledge, I've given a lot of talks. I think there are patients who actually come and ask us and say, hey, do you have that test, and can you tell me, like, am I at risk for delivery? What's going to happen to me? So I think it's been extremely useful, and I would agree patient education is a big part.
That's great info. So last question before we jump into our Q&A session. Did you make any other discoveries after incorporating the biomarkers in your practice?
Yeah, so what we did was, we did this is the study that was published after the FDA approval. So we essentially implemented the protocol, and then from June of last year, a month after the FDA approved it, to January of this year, we literally just collected data on all the patients who had the biomarker drawn. So we wanted to show that the use of biomarker is, one, safe, right? So nobody's going home and having like an eclamptic seizure, or nobody's like going home and coming back with a dead baby, God forbids. So we wanted to make sure that decisions that the physicians are making based on the test are safe. But we also wanted to kind of confirm the positive predictive value, the negative predictive value, like what's been published in PRAECIS, because PRAECIS was a research study. What we did was a real-world evidence. Real-world evidence is just to show the efficacy and safety of anything that you're trying to implement in real world.
Yes.
The results are available. What are the doctors doing? Somebody's going home, somebody's admitted, somebody's being delivered. We wanted to collect that information. And what we found was that actually our PPVs and NPVs, positive and negative predictive value, in this study, and it was a small cohort, about 60-some patients, was even better than PRAECIS.
Wow.
So our positive predictive value, for example, was close to like 76%.
Wow,
Compared to
that's great.
standard of care, remember I told you it's like 20%, and our negative predictive value very high, 94, 95%. The other thing that I found here, and those are called Kaplan-Meier curves, so you see those two lines. What it shows us that people with negative test, because we knew they're at low risk, if they had some other overlapping features, like somebody has elevated LFT, somebody has a headache from migraine, and those are all symptoms of severe preeclampsia, we'll say, well, your biomarker is low, so maybe you have elevated LFTs because you're obese. Maybe you have chronic hypertension, maybe this is just worsening hypertension, I don't need to deliver you. What we found was the rates of delivery preterm, and that's what it says here, was so much lower in people who had a low ratio. So the end of the story is that if you hold your hand and you don't deliver somebody with some suspicion, strong suspicion for preeclampsia, you actually can prolong their pregnancy safely, right? So right now there's no treatment for preeclampsia.
Yes.
So if you have a high ratio, you just observe them more and make sure that they are not being missed, which is a common reason for maternal mortality, is this delayed diagnosis, unclear diagnosis. So you can diagnose them correctly and follow them, but on the people who are low, you can actually withhold delivery, follow them expectantly and manage them expectantly, that you can have a prolonged pregnancy and reduced rates of, for example, NICU admissions.
Wow, that's really great info, and to know that the incorporation of biomarkers definitely helps the outcome of patients. It's great information and great knowledge to know. So thank you, Dr. Rana. So pass it to Jonathan.
If you have a question for Dr. Rana, please raise your hand and we'll be glad to bring a microphone around to you. Thank you.
Thank you so much, Dr. Rana. That's a wonderful discussion. So my question is, you highlighted positive and then negative predictive value a lot with biomarkers. And we know those two parameters are influenced by prevalence. So can you comment on how maybe the utility of these guidelines and these biomarkers differ in different geographical areas which have different prevalence and also different ethnicities, because it's more prevalent in, for instance, black women than in white women?
So we didn't show you the data, but we calculated the likelihood ratios. So the likelihood ratio for developing severe disease, severe preeclampsia within 2 weeks, was the order of 7, and a negative likelihood ratio of 0.09. So anytime you have a likelihood ratio of over 4 or 5, that's a clinically very useful test. So we didn't show you the data, but we did calculate the likelihood ratio, which kind of takes away your prevalence of the disease situation. Though I can tell you that one of the reasons they even did the PRAECIS study across 18 different sites in the United States was because of that exact question, because a lot of data that was published before that for the past decade was actually done in Europe, where the rates of obesity is very low. They are mostly Caucasian people. But now you guys have developed, these guys have data from Asia, where the patient populations are entirely different, pretty similar sensitivities, specificities, PPVs, and PVs. Our data at our institution is a little bit, I would say, quite similar to the PRAECIS study. PRAECIS study was a large study done all across US. So we have a very high prevalence of obesity. About 60% of our people who develop hypertensive disorder are actually African American black. So it is a high risk population. But I can tell you there's lots of data about LR ratios, likelihood ratios, which are very high and very low. So it's a good test.
Hi, Dr. Rana. What data needs to be generated for the inclusion of the SFLT1 PLGF ratio in guidelines?
Yeah, so I can tell you from, this is just my personal opinion, so don't quote it anywhere, but I think, I know. So when the way it worked in the European guidelines, so they did you guys did the prognosis study. That was a large study done, published in New England Journal of Medicine, but I think the physicians just adopted it and then wrote a lot of papers about real world application of the biomarker. I think personally in the US, I hope they don't demand an RCT, because that's such a high bar. Like, has anybody done an RCT for anything in obstetrics? Answer is like very few things. So I don't think we should waste time. I think we should, one, I would say just doing post FDA approval, real life, real world evidence studies from across different institutions, different geography, like you were saying, different kind of patient populations, and publish that data. I think that should convince ACOG.
Thank you, Dr. Rana. A quick question around your specific patient population and those suspected of severe preeclampsia. How many ratios would you say would help you identify those patients that would turn into preeclampsia? Would it be 1 ratio, 2 ratios? Like, what would be the test results that you would need to have confidence to move the patient forward in a diagnosis or a decision?
So right now, you can get it at 2-week intervals. So typically what we are doing, if you get a ratio and it's low, and the person is pregnant at the end of 2 weeks, because it kind of only, FDA says it only predicts for 2 weeks, and you still have suspicion of preeclampsia at the 2-week mark, you can repeat the test. And the way it is, at least FDA approved it, is each individual test is a snapshot in that person's pregnancy history for 2 weeks. So almost like agnostic of where it was before and where it is now. Though there is data from other places that there's a delta. If it rises quickly, then it means something else. Then if it's flat, I have published data that if you do it every day. But right now we are doing it at 2-week interval. Typically in my institution, we are not doing it once it's positive. Once it's positive, regardless of what the number is, whether it's 80 or it's 200, and I have patients over in thousands, we just treat them all the same. We increase surveillance. Anybody less than 40, and I can tell you in our paper, I have to go back and see, but the people who had a low ratio, the mean ratio was like 7. And the people who had a high ratio, the mean ratio was 500. So, people ask me that all the time, oh, what if there is a 39? There is no 39. You're either 2 or 3, or you're 200, 300. And it just like shows in clinical care, like I can see her blood pressures are rising up because I know that she's sick. And I think it's very kind of reassuring both ways. So yeah, so you have a valid question. We haven't really done that study. FDA has approved it only for 2-week intervals and repeat at 2 week and just treat that as a number.
So you mentioned this is only approved for inpatients. So
Yes.
I have a practical experience where my wife was actually diagnosed at birth when she was in labor. That's when she was, so she didn't have any of the urine protein or any high blood pressure at all throughout the
Yeah.
whole pregnancy. So what, first of all, do you think this would be useful as a screening tool? And then if it is, what kind of data is need to make it venture into that space?
So yeah, so good question. So for everybody to understand, we are not screening here, right? So FDA did not, so screening is a test that you applied on asymptomatic patients. Currently, the current indication is patients who are being evaluated or being admitted to the hospital with some sort of hypertensive disorder. So good question, but we are not there. So right now we are saying we're going to take these patients who have some sign and symptoms. So most of these patients actually in these cohorts are chronic hypertensives who are admitted with worsening hypertension. Gestational hypertension, you don't know which way to go. Patients with transaminitis, worsening creatinine, have tons of patients with renal transplant, kidney dysfunction, lupus. They're worsening creatinine and you don't really know what's going on, preeclampsia or not. But you have a valid point. So there are studies outside of US done where people are really trying to figure out screen in first trimester, stratify. Screen in mid-trimester, stratify. Screen in third trimester, stratify. And in fact, like people are proposing that perhaps people should be going different paths even in late pregnancy to see, perhaps people need to deliver based on if you have a high ratio at 37 weeks versus low. In US, none of that. In US, we are very limited. We are really limited to these inpatients, but I think it's a big step. Just to even have that available is a big step, but all valid points. Yeah, those things have to be done.
Hi, Dr. Rana. So on one of your earlier slides, you show a downward trend in the deaths, especially in black women, so from 69 to about 49 on one of your earlier slides.
I think that was the rate of maternal mortality across different races.
Yes. So
Yes.
that's not related to preeclampsia.
No, so if you draw a graph like that for preeclampsia, it will be very similar. So the maternal mortality in women who are African American black is higher than people who are white, and it's also higher than people who are Hispanic.
So looking at just the black population,
Yes.
there seems to be a downward trend from 2021 to 2022.
Sure.
What is accounting for that downward trend? What are we doing that maybe we should continue doing to see a much more lower trend?
So we can go back to the slide, but that is the national data. That was the slide, the difference between the two. I can tell you personally that there have been a lot of, first of all, thanks for coming here and talking about it, because I think talking about maternal mortality is a new concept for us. I mean, people were dying all the time, but people were not talking about it. So I think just talking and making people aware that there is a real risk to people, and that risk, I mean, unfortunately, we kind of call it race, or we have to call it racism, right? Because it's not the race of a person. Just because you're black doesn't mean anything. What means is that what you've been exposed to and how you're treating in the health system. So definitely talking about, these things that are affecting our black moms more, creating pathways for them so that the system is ultimately responsible for them. And I personally think like biomarkers is, hopefully if it's universally implemented, could be a game changer, because you kind of take the subjectivity out, right? So it doesn't matter whether you are black, white, purple, big, small, gray, yellow, doesn't matter. Like if you come in with some hypertensive disorder, I'm going to do this test and I can stratify you much better for your risk, rather than thinking, oh, if you live in that neighborhood, maybe you're a high risk. Oh, maybe if you're exposed to this, you're at high risk. So I think some of these strategies, but for now, I think there's a lot of talk about it. I think a lot of people are thinking about what they can do system-wide to help the moms.
Unfortunately, this challenge is with women presenting themselves in the emergency room is very common that their symptoms are overlooked. What advice can you give women to advocate for themselves in a healthcare setting that may help them be perceived as, sincere? Is there any advice you can give?
Good question.
Yeah, very good question. So I would say that I tell this to my patients, that always bring somebody with you. I feel like what happens if you're sitting in that in that bed and there are 4 other people around you, I think you kind of lose your voice. So I always tell my patients that bring somebody with you. So if there's another person who's not in that bed, can actually listen and talk, I think that's a good advice. And the other advice, I think I would just like in general, in the health system, I think you should always escalate. That's what I say. So if whatever he's telling me doesn't make sense, you say, you know what, I respect you, but what you're saying doesn't make sense. Is there somebody else I can talk to? Like, everybody has a boss. Like, unless it's the president of the hospital, everybody has a chain up. So you can always speak up and say, this doesn't make sense. My doctor didn't tell me this was happening. Can you call my doctor? Like, where is this going? I don't really understand. So I think just be like a little bit active. And then
being an advocate.
Be your own advocate. And I tell my patients all the time, like, be an active participant in your care. Like, you should be telling me what I'm telling you even makes sense to you. This is work for you. What do you think I should be doing? So I think just educating our patients, and I agree, like a lot of patients are intimidated. It's like a new environment. Like try sitting in one of those beds yourself. It's very intimidating. 4 people come at you. So I think those will be the advice, like being your own advocate, because these things are happening every day. And people are slipping through the cracks and literally not having good outcomes. So I think, being your own advocate and just escalating the chain of command may help.
So thank you for that presentation. Can you, Dr. Rana, speak to how the conversation went between you and the laboratory to implement the guidelines? The biomarkers, and how to get buy-in from everyone.
Yeah, so I agree with that. So there was obviously, in all disclosure, the platform that is currently approved is the Thermo platform. So not the problem, but it is a machine. I think that was one of my biggest hurdles, was to convince the folks in the lab to buy the machine. That way I feel like you have an advantage, because Roche machine is the usually used platform. I had to really create like a memo that I had to send to my lab manager. I'm also the section chief for MFM, so I kind of run all hypertension clinics, so I think I had some advantage. But we made a very strong case that this is now approved by FDA. It's been studied on thousands and thousands of patients, and seems like it's a useful test. And then we just kind of said that we need to do this for our patients. And we also made a case that it can ultimately prevent prolonged admissions, but also ultimately prevent prematurity and help the babies in the NICU. So I think you just have to make a very strong medical case and say this is helpful for our patients. It will reduce adverse outcomes. And we are in South Chicago, so we have lots of adverse maternal outcomes. So we had to make a case almost from disparity, that we suffer so much from disparity. Our moms are like so disadvantaged. So we need to do this stuff, whether it's like works out in the end or not, but we need to put this for our patients.
Do we have one more question from our audience for Dr. Rana?
Thank you for listening. Yeah,
Thank you for your time.
Thank you.
Thank you.
Excellent. Yeah, thank you.